Hi everyone, and welcome to our 5-minute guide on a fascinating congenital anomaly of the urinary tract, the ectopic kidney. While it might sound complex, by the end of this video, you'll have a solid understanding of its embryology, clinical relevance, and management. As medical students, you know that our kidneys are normally located in the retroperitoneal space, high up in the posterior abdomen, roughly at the level of the T12 to L3 vertebrae. But what happens when one or both kidneys don't make it to their final destination during development? That's precisely what an ectopic kidney is, a kidney located outside of its normal position. Let's quickly revisit our embryology. During fetal development, the kidneys begin their journey low in the pelvis. Between the 6th and 9th weeks of gestation, they ascend to their final lumbar position. This ascent is a complex process involving differential body growth and the straightening of the embryo's curvature. An ectopic kidney results from a failure or an arrest in this migration process. The incidence of ectopic kidney is estimated to be around 1 in 500 to 1200 births, but many cases remain asymptomatic and are discovered incidentally. There are several types of renal ectopia, and it's crucial to know the main classifications. Pelvic kidney. This is the most common type, where the kidney fails to ascend from the pelvis. Abdominal kidney. Here, the kidney's ascent is halted somewhere in the abdomen below its normal position. Thoracic kidney. This is a rare form where the kidney ascends too high, passing through the diaphragm into the thoracic cavity. Crossed renal ectopia. In this variation, a kidney crosses the midline to the opposite side. The ureter of the crossed kidney still enters the bladder on its original side. These kidneys are often fused with the normally located kidney on that side, a condition known as crossed-fused renal ectopia. A key feature of ectopic kidneys is their anomalous blood supply. Instead of receiving a single renal artery from the abdominal aorta at the L1 to L2 level, they often have multiple aberrant arteries originating from the aorta or iliac vessels. This is a critical consideration for any surgical planning. So, how does an ectopic kidney present clinically? The majority of individuals are actually asymptomatic throughout their lives. When symptoms do occur, they are often nonspecific and can mimic other conditions. These may include abdominal pain. This can be vague or present as a palpable abdominal mass. Urinary tract infections, UTIs. Due to altered anatomy and potentially impaired drainage, patients with ectopic kidneys are more susceptible to recurrent UTIs. Urolithiasis, kidney stones. Stasis of urine can lead to stone formation. Hydronephrosis, obstruction at the ureteropelvic junction, UPJ, or vesicoreteral reflux, VUR, can cause the kidney to swell. In fact, VUR is a commonly associated anomaly. It's also important to remember that ectopic kidneys can be associated with other congenital anomalies, particularly in the genital, cardiovascular, and skeletal systems. The diagnosis of an ectopic kidney is primarily made through imaging. Ultrasound is often the initial imaging modality, especially in antenatal screenings or when a patient presents with abdominal symptoms. Computed tomography, CT, urography is the gold standard. It provides detailed anatomical information, including the kidney's location, its vascular supply, and the presence of any complications like stones or obstruction. Scintigraphy, such as a DMSA scan, can be used to assess the differential renal function. Now, for the crucial part, management. The good news is that asymptomatic ectopic kidneys with normal function generally do not require any treatment. The management strategy focuses on addressing any complications that may arise. For UTIs, standard antibiotic therapy is the mainstay. For urolithiasis, treatment depends on the size and location of the stone and may involve medical management, shockwave lithotripsy, or surgical removal. The abnormal anatomy can make surgical access more challenging. For obstruction, if there's a significant blockage, for example, from UPJ obstruction, surgical intervention like a pyeloplasty may be necessary to improve drainage and preserve renal function. Nephrectomy is reserved for rare cases where the ectopic kidney is non-functional and causing recurrent severe symptoms. So, let's quickly recap the key points for you to remember about ectopic kidney. It's a congenital anomaly resulting from failed renal migration. The pelvic kidney is the most common type. Most cases are asymptomatic and discovered incidentally. When symptomatic, it's often due to complications like UTIs, stones, or obstruction. Diagnosis is primarily through imaging, with CT urography being the gold standard. Management is tailored to complications, with most asymptomatic cases requiring no intervention. Understanding ectopic kidney is a great example of how embryology directly impacts clinical practice. We hope this quick guide has been helpful. If you found this video informative, be sure to like, subscribe, and hit the notification bell for more concise medical content. Thanks for watching.